So this is going to be a panel discussion. We'll take questions from the floor almost immediately. So start thinking about your questions from the floor now, please, about digital and more at home. So basically, I mean, clearly COVID has shown that the consumer and patient. I'm not really happy with this word consumer. I quite like the word patient. I don't know why I don't like the word consumer, but I find it... Anyway, we'll come back to that. So you've got the consumer and the physician, and they're willing to do more at home. You know, got telehealth tests. We've all done the tests. And the monitoring. This should save money and lead to better outcomes. So this panel is really looking at what progress has been achieved and at what it's going to look like in 3 or 5 years' time. So let me introduce the panel. Hi, Paul. So we have Carlos Nueno, who's President International for Teladoc Health. Teladoc is the world's largest telehealth player and now offers virtual care services for patients, doctors and hospitals. It bought Livongo, the chronic disease platform in the States, and it then bought InTouch, which does a lot of telehealth and linking in hospitals. So it's doing the whole 9 yards. And the group has a market cap of $22 billion. And Carlos is in charge of spearheading virtual care services, I think starting with the private sector, but then moving on and building up the entire range of Teladoc services, including the launch of the Livongo platform in 2022 in Europe. And his background is he built up and co-founded Advanced Medical, which was a global second opinion and medical triage provider, which was bought by Teladoc. So we've got Catherine Ward. Catherine is the Chief Commercial Officer at Healthy.io. This uses a smartphone as a device to enable the consumer to carry out an increasing range of medical selfies. So you can diagnose whether you've got a urinary tract infection. You can diagnose, you can identify kidney disease. You can do wound care, or you can look at your pregnancy if you're a woman. And Healthy.io raised $95 million and is active internationally, particularly in the US, Israel, and the UK. Catherine is a former chief executive of United Health UK and was the growth officer at Optum International. And Paul Stevens is a director for connected services and solutions to Omron. Omron, you'll know Omron because it does the blood pressure monitors. It's the leader in blood pressure monitors. And its healthcare division does over $1.1 billion a year, selling both to the consumer and to healthcare systems. Paul leads Omron's approach to remote monitoring, digital patient engagement, and B2B solutions, including the home screening for stroke prevention, and new tools which merge genetic data with monitoring devices. So we've got a really interesting panel here, guys. So I've got some questions, but does anyone have any particular question they would like to start the conversation with? More at home. Yeah? Well, think of a question. There's a question there, gentleman over there.
Good morning. My name is John Deverell. I'm from GE. My question is, and in advance of anything you might say, in the continuity of care, home is increasingly important, as we've heard yesterday and today. Do you see it, though, in your endeavors, in your business, as something which is separate from what happens in hospitals? Or to what extent, how do you manage the interface with what happens in the hospital for patients who are people who are long-suffering or who wait, as I remember, which is why people use that word, or for consumers who are something else?
That's an interesting question. So how do you manage that home-hospital interface? Carlos? You know.
Well, thank you. First of all, thank you for inviting me here. It's been 18 months since I didn't have the chance to come to London, so it's great to be here, especially face-to-face. Well, you know, we've heard from hospitals. We also heard from digital companies. I think you mentioned the consumer and whether we should call the consumer or the patient. At the end of the day, we as patients, we want to have access to healthcare as we want to have access to everything else in a very convenient way, in a fast way, with quality, and from home. And so I think the debate is not so much how do you transform hospitals to become digital players or vice versa. I think the point here is how we all integrate each other and collaborate and partner so that we can bring the best of each world to the consumer, to the patient. At Teladoc, we've been clear on being a digital company and being able to provide all these services and capabilities to the patient with immediate access. And I think there are three components. One, being able to be with the patient wherever the patient is, whether they are at home or whether they are at the hospital or outpatient clinic or working or traveling. Then being able to integrate the different layers of healthcare, not only primary care, but also being able to be there before you have any disease, wellness, prevention, but as well going towards complex care, acute care, chronic care. But I think the key is how do you integrate all of this in a way that these are not siloed solutions, but really integrated. And the last one is how do you connect with the patients, which methodology, which channels of communication you use with the patient, whether you use the more traditional ones or you use more digital communication or you nudge the patient. For instance, in chronic care disease, what we do is we combine the devices on one hand side with AI so that you can use the data of the device to transform these into actions so that you really can have an impact on the patient. And then how you then integrate coaches or human beings, clinical professionals, so that they can also interact with the patient when it's needed. So what is the right balance? I think that's the key. And I think the beauty is how you integrate. And not everything has to be done by one provider. I think the key is how do we partner together?
It can be done by several providers. So, Catherine, I think you've got a great example, actually, of the integration, haven't you? With you and Paul are both working on you've got examples of projects where you're integrating, aren't you, within the healthcare system. Tell us about your one on Healthy IO.
Yeah, but I mean, I think Carlos hit the nail on the head by describing integration as, the nirvana that we've all been trying to seek between primary, secondary, tertiary care, between public and private, between all the different kind of ways in which people interact with the healthcare system. I would say that the work we do at Healthy IO, where we're taking the smartphone camera and transitioning it into a clinical grade diagnostic device, actually is enabling at one level, the reach of the hospitals into a broader engagement with their patients over time. So it enables people to test in between outpatient visits, for example, so that you don't have to organize the patient to have to come into a building each time. I think we've had a huge kind of revelation during the COVID period that not all care does have to be face-to-face in a hospital setting, but actually if you're going to use an alternative digital platform, having the right diagnostic underpinning for that and enabling then some interaction with the patient when they're not in front of you is really important. And it's not enough just to see them on a video or talk to them, actually having the ability to enable them to test at home.
And you're doing that in the tens of thousands with the NHS?
So
Tell us the numbers on the NHS contracts.
Just one example for the work we're doing on screening for kidney disease in the NHS. We have a contract for 640,000 people with diabetes and hypertension to have their urine tested. It's a nice guideline that once a year they should be testing. The current pathway requires them to come into the practice, the GP practice, pick up a pot, take it home, do a sample, put it in their handbag, bring it back into the GP, forget to do that, be given another pot, asked to bring it back another time. Once the sample finally reaches the GP surgery, it has to get posted to the hospital. They then have to undertake the test in a lab, and the result then comes back. So instead of that, we're taking the names of everybody who hasn't had their test in the last 12 months. We're texting them. We're dropping a kit through the letterbox, which is then lands in their at their home for them to test at their convenience. once they do the test, which is pot, dipstick and a colour board with an app on the phone, they take a screenshot of the, it's just a screen grab of the colour board with the dipstick. That translates into a clinical grade result substantially equivalent to the point of care analyzer, which then goes back into the electronic medical record in real time. So you're saving the primary care physician and the practice all of the palaver and aggravation of chasing the patient up and having to have all of that practical kind of process. The patient doesn't have to leave the house, and yet the result is then in the system.
And you've got very high levels of compliance on this, haven't you?
So we're only working at the moment with the patients that haven't tested in the last 12 months, and they've been chased up at least 3 times by their own practice to come in and do the test. And we're able to get to 53% of those patients doing the test through a digital means. So these are people, some of whom we've just done an audit on some of the work we're doing in Tower Hamlets. Some of them haven't had their test done for 15 years. So it's a real kind of breakthrough to actually get those people then engaged.
So you're ringing them up on the phone and...
Mostly we're texting and sending the kit, and that's enough to get 40% of people to do the test without even prompt. And then because it's very intuitive, it's kind of cool, it's a nice kind of bit of kit. And then we have a combination of outbound and inbound calling and nudging to just get the ones that haven't done it immediately over the line, and we can then get that number right up over time. But the significance of that is that if we've got a health economic model that York Health Economic Consortium have built that shows if we're to reach only a third of patients in England who haven't done their check, this is patients with diabetes who haven't done their check in the last 12 months, we could save the NHS £209 million in 5 years, because you're actually picking up end-stage renal disease, chronic kidney disease, you're picking up before transplantation's required, before there's a need for dialysis. And essentially, huge opportunity there from population health perspective to drive value, as well as improving the convenience for the patient.
Great. Okay, thank you. And Paul, you've got a similar example, haven't you? I think also in the UK. Is it in Dorset? Is that right? Or
yeah, that's right. In Dorset and northwest London, we're supporting primary care with management of chronic diseases. So starting as our base as a company, as you said in your introduction, is mainly around cardiovascular disease and blood pressure. We've started working with those areas on the model of supporting management of hypertension remotely. And I think what's really interesting in the value proposition is that we're seeing a shift away from the model of those patients being managed by their GP in their individual practice to actually the patients being managed at a larger scale. So in the UK, you have these groups called primary care networks, which are around 4 or 5 GP practices that are required to work together. And we're deploying our service actually at that primary care network level. So the workload of managing chronic disease is being shifted from the GP practices and the individual resources to a more centralized approach. And that essentially enables the GPs to spend more time with the patients that need that additional attention. So I think to the audience question as well around that balance between face-to-face and remote, where we're able to support people to be managed remotely, and we've built our service on the basis and know-how of clinical evidence that shows that this approach is effective. It actually means that those patients that do want a face-to-face appointment and those people that need that extra care and attention are able to get that from their GP practice because they have more time. And at the moment, we're covering practices that have kind of a total population of more than 100,000 blood pressure patients. So it's a very large group of people that typically take up around 12% of all GP appointments. So you can see the potential to be able to save that time and improve care as well. The clinical studies show that we can reduce the population blood pressure by around 5 millimeters mercury, which translates into a more than 10% reduction of stroke and other cardiovascular events. So not only are we saving time in primary care, we're reducing strokes and heart attacks, and therefore saving both time and money at secondary care and improving the lives of the patients as well.
Right. Okay, thank you. So So they are. It is. So you are getting this interface, aren't you? Then I suppose the question is really what resistance there is to. I mean, there's a lot of. I think historically there is a lot of resistance from physicians and from healthcare systems to radical change, isn't there? There is a sense that. I remember talking to a social democrat politician in Sweden, and they came up with something similar, and they found they really gave up in the end. They gave up on the idea of stopping the patients from going into the clinics because the people in the clinic said if they don't come in, we lose our jobs. And actually, in the end, he said, I lost that battle. I just lost that battle. It was clearly a better system, but I lost the battle. And that was 5 or 6 years ago. So do you not see that kind of problem? Or, I mean, it's interesting that you're both NHS cases. I don't know. How much resistance is there to this kind of thing?
So I think there's been what I've been describing as a closure of the imagination gap during the last 18 months, where 2 years ago I might have gone into a hospital to meet a group of nephrologists who would have said, this is really cool, patients are going to love it, oh yeah, this is exciting. And then they would have said, yeah, but the patient has to come in anyway, and they don't mind bringing their sample in. And just bear in mind, for a kidney clinic, it can be an hour and a half on the train for a patient to come into the clinic with their sample. Oh, and no, we do the urine tests at the end of the clinic, and it's only an extra 20 minutes, and nobody minds that. And so it's a little bit back to the Francesco's point about when will the consumer actually become a consumer, and actually be the service ethic be important enough in a public government-sponsored health system to actually make a difference. But I think now that they've proven the ability to do more of a digital interaction as a day-to-day, and that not every patient has to come in for every face-to-face interaction, there's now much more open-mindedness, I think, about the value. And I think that comes alongside a huge kind of revolution we've seen in the last 18 months with lateral flow testing, and the sort of sense that everybody is now into a mode of testing themselves at home on a regular basis, as part of normal life.
So that's really changed.
Yeah, I'd say so.
Carlos, is that your impression as well? Or, you've been going around Europe, haven't you? And
yeah. Well, I think it is changing and has changed, but I don't think, I've been 20 years in this field, and providing second opinions and medical triage services, and this is something that we already tested several years ago. So the fact that if you provide fast access, quality care sooner to the patient, and use technology to do that, you can save a lot of unnecessary things. That's proven everywhere around the world. Now the point here is, how do you do it scalable? How do you do it with security of information? How do you do this with quality? And not replacing the existing providers or the existing doctor community. I think it's not about replacing, it's about how do you enhance them with the right tools and technologies so that they can do their work faster, easier, more efficient, but it's proven. And so, of course, COVID-19 has brought a radical change in the sense of providers, hospitals, not being able to see patients, and therefore everybody jumping immediately with technology, with whatever technology was at hand. Now I think we are entering into a second phase where we are going to see how all these technology is going to be integrated and well thought, so that we can provide all these services to the best quality to the patient.
Yes, in a sense you've got a problem, haven't you? Because GPs or family doctors around Europe think they've been using telehealth, when actually they've been on the phone or using Skype. So they think they know what telehealth looks like, and they can see limitations in it, which they then think reflect telehealth. But actually, they've been using about a third of a system. So you've got a big educational job there, haven't you, I guess?
Well, and also there is a great opportunity. You see the opportunity of really providing the best technology to the GPs and to the clinical community in general. We have an experience with the NHS through one of our subsidiaries here, Consultant Connect, which what they do is they provide access to consultants to the GPs, so that when you go to the practice, you may be seen by the GP, but if you have a specialist consultation, instead of waiting for several weeks, the GP can immediately get in touch with a consultant and have the consultant in the room virtually. And so being able to empower the GP to do more work more efficiently, and reducing the need then to wait in the waiting list if that's not really necessary. So I think these are examples that you can increase efficiency, multiply efficiency
Yes.
in the healthcare system.
Yes. Okay. So another question from the floor? Who's got a question? This panel. Yeah, there's a question there. Lady in the white jacket.
Hello, my name's Evelyn from 21DX. My question is predominantly to Catherine, actually. So you talked about your work in kidney disease, but judging by your website, there's lots of other things you do, like UTIs and antenatal care. So I've got a two-part question. Why is it kidney disease that you started in and that you've managed to work at scale with the NHS? And where do you see sort of the next steps for further expansion, maybe into other disease areas? Thank you.
Thank you very much. So essentially we have three versions of the urine testing kit. One that has the 10-parameter dipstick, which is most commonly used in outpatient and primary care settings. Has 43 million uses in the NHS every year, just as an example, 200 million in American outpatients. We have a second kit that has a subset of that dipstick, which is leukocyte nitrite in blood, which we use for uncomplicated UTI in 16 to 65-year-old women. So being really mindful of the issues around antimicrobial resistance for use of dipsticks in older people. And then the third is the albumin to creatinine ratio, which is what is used in kidney disease. I started actually with a 10-parameter dipstick, and the joy of working in the NHS system is that each one of those three kits has a different buyer. So I basically sell the 10-parameter dipstick to hospitals, the urinary tract infection to retail pharmacy, and then the kidney disease to the payer, to the CCGs, PCNs, ICSs, whatever acronym you've got for the current setup in the NHS. I think the nice guideline that exists for kidney disease screening, and the fact that there's such a gap in how that's delivered, so only 30% of people with hypertension, for example, do their annual urine test at the moment, was a really good hook for engaging the NHS on that scale. The sense that there was a huge community around diabetes and a lot of emphasis on the importance of tackling issues relating to diabetes as a sort of policy issue was another hook. And we were very fortunate to be awarded a substantial award as part of the Accelerated Access Collaborative, which is an initiative the NHS has to try and get digital products to scale to allow us to escalate to that scale. We are just seeing signs that the others may be coming up behind them. So we have, for the 10-parameter dipstick, there's a use case around urology where if you have a day case cystoscopy, you do a dipstick as you arrive as a patient in the hospital on the day. And if you have a UTI, which 8% of cases do, you are actually cancelled on the day. So there's a huge amount of wastage around surgeons' time, whether the kit's being used, the equipment's being used, and obviously frustration from a patient who's taken half a day off work and ended up having to go back home again. So instead, we're sending kits a few days before the appointment. We're able to then transfer them into a fast-track UTI treatment pathway, and then either you can get the patient back into their original slot, or you can bring a 2-week waiter into who's urgently needing the intervention to it. So we're just getting actually some really good traction as a commercial bottom-up approach to the service with that option. And of course, once you're established and part of an infrastructure, there are so many other smaller groups of patients in various pathways that you could really drive. Globally, our experience has been maternity is the big one. We're in 3 of the HMOs in Israel with really good traction and uptake. Interestingly, that isn't one we've managed to get any traction with in the NHS, where the general view is that this would be a luxury for women to not have to carry their pot in their handbag on the way to the practice. So we're still trying to work through the health economic approach to that, and unleash the power of women to refuse to have to carry their pots of pee in their handbags all day before they get to their clinic appointments.
So it's interesting, isn't it? Because you really have gone out and understood the entire system and then working out where you've got the pressure points and how that works. I guess the economics is not hard to argue about, is it really? I know, Paul, you bought Lucy, didn't you? And you bought Lucy, didn't you, in the Netherlands?
We're investors in Lucy, yes.
Yes.
We don't own them outright, but we are investors.
Okay. Because I think they actually have a way of treating people so that people who are early stage Alzheimer's patients can stay at home longer. The figures I saw from a Dutch local authority were that they could keep people with early stage Alzheimer's at home, I think, another 10 or 11 months. Was that right? I didn't dream this, did I? It was a couple of years ago. They were showing that kind of by monitoring people at home, they would stop them having to go into an institutional home for nearly a year, which is a huge saving.
Yeah, that's right. Lucy has done a huge amount of work in the Netherlands. They're now working with more than 60% of the hospitals there and are covered by all of the major insurers. And they have programs covering kind of multiple chronic disease areas. They originally started out in heart failure and diabetes, and indeed are able to show that they can monitor people effectively at home. In effect, it's a blended solution with Lucy's platform and monitoring nurses. So the community nursing system is important as a part of that ecosystem. But the benefit is that rather than having those community nurses going and visiting these vulnerable patients at home, they can do a large amount of that monitoring and recovery work remotely. And so the community nursing teams can actually support more patients. And that's where those significant kind of economic and health benefits come in. And Lucy's recently shown the same impact in a large project that they've been running with the Sunderland CCG. And Lucy are having success now expanding out into other CCGs and ICSs across the NHS.
Good. But any other questions from the floor? Yes, good question there.
Hello, can you hear me?
Yeah.
The question basically goes more or less to Carlos. In order to grow with Teladoc and to not only offer telemedical services, but maybe more, how important is physical presence for you?
Physical presence in what sense?
How important is physical presence in terms of like having nurses and doctors on site and offer telemedical services in addition, or offer just diagnostics on site and then do the whole doctoral part via your platform?
Right. So Teladoc has three major business lines that have been integrated, and they came through former acquisitions. So we have what we call a virtual care service, which today provides service for more than 70 million patients around the world, with more than 14 million virtual consultations last year. And that's mainly provided usually through collaborations and partnerships with insurance companies, employers, and the health system in general. And so there we provide our technology plus our healthcare services, which are provided through our own either employed or contractual clinical professionals. And we do that in a number of different countries. In the US, of course, where we started and became public in 2015, we cover all 50 states, but we are present in more than additionally 20 different countries. And on top of that, we serve international companies that have patients all around the world. So we get cases from hundreds of different countries. Then we have a second line, which is more to your point, how do we provide service and enhance providers like hospitals and health systems to integrate the right technology. And so we have our own platform that we are able to license to them and not only platform, but as well hardware in the form of devices or monitors, screens, even robots that we produce that allow hospitals to provide service beyond their physical limitations. And so that's a second business that we have, came through an acquisition last year or 2 years ago, a company called InTouch Health. And this is a pretty global business that allows us to work with hundreds, if not thousands, of hospitals around the world. And then we have a third one, which is how do we integrate chronic care devices within virtual care, which came through this acquisition of Livongo last year. And so I think that Teladoc's mission is to use all these capabilities, again, wherever the patient is, whether it is at the hospital, outpatient clinic, or at home, or traveling, being able to use all these capabilities to provide the best care to them. And in some cases, we would provide a medical service. In some others, and usually with public health systems, we maybe just provide the technology so that we enhance their own capabilities, but they integrate their healthcare professionals into our technology.
Right, so because you're on the adoption curve, the first people to adopt and sell to were the insurers,
Yep.
And second
Lawyers.
opinion providers in the private sector, and then you're going into the public sector later, you see, or
Yeah, well, and again, public sector is a definition which is complex because
of course,
every
yes.
country has their own public system, and we've heard about regulations. So, but in general, and outside of the US, you would expect public systems to use technology to provide more efficient services to the population and needing to integrate those with their own clinical professionals. So it's not so much that Teladoc would then provide the healthcare service, but how do we integrate the technology in their systems so that they can provide that enhanced experience to the consumer?
Yes, yes. What's interesting is actually, I mean, I don't know to what extent you're international in terms of what you're covering, Paul. I mean, in terms of the B2B and the more complex solutions you're rolling out, is it mainly at the moment in the Netherlands and the UK, or is your revenue, is that the main areas, or Japan, or how international is it? Because I mean, I think at the moment it seems almost people are, it's national.
Yeah, I think that's a great question. And actually, as Omrad, we're taking different approaches in different areas globally. So because of the insurance system in the US, for example, we take a different model where we're really focusing on secondary care, chronic disease management, and supporting those really high-risk patients. In Asia, we're focusing more on employer health systems and supporting people to stay healthy and remain in work. And in Europe, we have this focus on primary care because we see that's where the biggest challenge in the system is. And at the moment, for the European system, our kind of proof point is in the UK, but we are actively looking at which markets to go to next. And as Carlos mentioned, the regulatory and the reimbursement structures are a big driver on what's possible, and making sure that the services meet those frameworks, particularly around how do the people who are doing the work on the clinical side get paid for the work that they're doing, is really kind of the key to being successful in those markets.
Yes. So for you, I mean, how urgent is it to get international? Because I mean, in a sense, you can build you're building a really good business case, Catherine. I can see it. It sounds fantastic for a part of the NHS in the UK. And then I guess the Healthy IO investors are going to say, we want you to be global. We want you to penetrate these markets before other people come in, and That must be a business imperative. How do you square those two things? I mean, that must be very difficult.
So yes, we've definitely tried to keep focus in the first few years. People will be aware, I'm sure all of you happens too, where you get LinkedIn requests from all sorts of parts of the world with people who've got this distribution network that's to die for, and they just need your kits to be to fulfill their dream of how they're going to take you to X and Y. And when you're in the first stages of a startup, it's quite tempting to kind of chase these different kind of shiny objects around the world.
Yeah.
So instead, we've been very focused. I think we're pretty unusual at focusing in on the UK first. Partly that's our founder was previously the chief technology officer for Shimon Peres when he's president of Israel, traveling the world to try and position Israel at the forefront of genomics and stem cell research and immunotherapy and all these big ticket items that are going to transform healthcare as the penicillin moment of the 21st century at some point, but realizing that the biggest investment in tech is actually the smartphone camera because of the 8 billion selfies that are uploaded to the cloud every day, mostly my children, and that if you could take those into healthcare, you could get transformation to happen more rapidly, but also at low cost to a government-sponsored healthcare system because essentially the tech companies paying for the hardware and the software and the consumers buying the device, so it should actually be both quick and cheap to get it kind of embedded and scaled. So for that reason and for his kind of commitment to public service, having grown up in kind of government space, the NHS in the UK was where we started, along with Israel, which
Yes.
I guess has a similarly, it's a bit more hybrid, but similar kind of system. We're working through final kind of commercial approval for our FDA 510K. At the moment, we've got 2 out of 3 kind of steps completed. We've got 2 510Ks done, but we've got 1 more to get through. And then I think it's going to be potentially quite hard for me to keep that focus on the UK because as we've already described, the opportunities and the scale of the US is very much a different league. But we're also really clear that having proven ourselves out in the NHS, which I think people tend to agree is a really difficult market to crack, that's actually pretty good credentials for us to then go to other European and global markets. So we're actively looking at the Netherlands and Germany at the moment. We're almost through our regulatory approvals in Japan. We've got strong interest from a global partner that we have to take us into Australia. So we're just on that kind of cusp at the moment of taking the leap into multiple markets.
Yes, and you at Teladoc, I mean, I know you're making about 10% of your sales are international outside of the States. So it's a big market to penetrate. I mean, how do you then prioritize which ones you're going? What are your priorities? Which markets are you going for first? Then?
Well, first of all, we have a long experience on international markets.
Yes.
Because of the different companies that Teladoc has been acquired that had more than or close to 20 years of experience internationally. So and I completely agree. So we don't have to be obsessed by trying to be everywhere at once because healthcare systems are very different. There are many regulations, and the one thing you cannot do is jump those regulations. So you need to be careful what you do and how you do. Unfortunately, because still there are too many regulations, and that's in many times against patients' accessibility to quality healthcare. However, we are very present in European countries, most of the European countries, where we have a long tradition and experience, countries like France or like the UK, Spain, Netherlands, Denmark, for instance, where if they have something in common is that they have a great healthcare system. So you would think, well, is telehealth for countries that don't have the right healthcare system or they have huge gaps in accessibility? Well, we do have services in Brazil and we have services in Asian countries. But the truth is that going back to the consumer is expecting immediate access to everything. And healthcare being the most important thing,
yes,
has to be accessible. And so that applies mostly, in my experience, to mature countries that have well-established healthcare systems that still don't have the right tools and services and the right integration so that healthcare can be accessible from home anytime. I think that's why we have had more investment and more presence into mature economies like the UK or European. But then we have, again, a great partnership going on in Brazil with a telco company that allows us to provide services to a wide part of the population.
Well, that's quite a new deal, isn't it, with Telefonica, isn't it, in Spain and Brazil?
Right.
And that's reaching, you hope to reach a real mass market there, don't you?
Yeah, that's when you realize that there are vast parts of the population there that don't have access to healthcare. And so we can provide an initial primary care service through a telco company that do have the platform and the services. And if one thing is common today is connectivity. And so I think there are 5.8 billion people with cell phones, with mobile phones today. And so on Earth. And it's about the next few years that everybody will have a mobile phone on Earth. So there are ways to enter into those markets, different ways, more direct to consumer probably. But on the other hand,
So that's a subscription model, a bit like Francesco's model in Spain, where you pay a certain amount a month, and that gives you access to primary care with the Telefonica and Teledoc.
Exactly, yes.
And that's, because Telefonica's been trying to do this for years. I mean, I can go back 7, 8 years and hear Telefonica talking about telehealth. So why has it not worked before, and why is it going to work with you?
Well, I think the reason why, because many things have changed today. And mostly, we had a pandemic that realized that there is a lack of access globally to healthcare. And if you think about a telco company providing connectivity, it is a good channel, at least, to think about whether you can add healthcare services. And so we'll see, but this is, the first results that we are seeing are pretty impressive in terms of the adoption.
Oh, really?
Yeah.
Any numbers?
Well, there are some numbers, but we don't disclose those numbers. But clearly, we see that as a very interesting partnership. We have another one, which is sort of interesting in the US, which is through CVS Aetna, which allows CVS patients that go into pharmacies, for instance. CVS has thousands of pharmacies, and they do have this concept of the minute clinic, which they provide
Yes.
primary care into the pharmacy. So we have partnered with them to provide primary virtual care. We call it Primary 360, which in a way is you have your GP through CVS, so you can connect virtually. You have a care team that can organize primary care appointments, potentially as well, diagnostic tests as well.
So you can get the stuff prescribed when you're in the pharmacy, really?
And then you can be referred to the pharmacy if you need primary care face-to-face service before going to the hospital level. So that's an interesting concept as well. It's growing very well, and the Primary 360 concept, providing a longitudinal relationship between a GP and the patient, but virtually, and organizing all the GP appointments virtually first. And it's financially incentivized by zero co-payments if you use that service instead of going to the normal face-to-face appointment.
Right. That's a fascinating business model, isn't it? Another question from the floor? I don't want you to feel you're being ignored, or... Okay. They all look very attentive, don't they? They're listening, which is good. Yes, there's a question here. Hi.
Yeah, I'll try one. Oh, is this on? Yeah, okay, hi. Hi, I'm Cindy Williams, and I'm the founder and CEO of Quinn, which is digital therapeutic for self-management of diabetes.
Oh, hi, Cindy.
Hi there. My question actually is, I've been trying to formulate it into a question and not an opinion, because it is actually a question.
I like opinions.
But I guess it's just, we've heard a lot about, you started, Max, saying consumers, I'm uncomfortable calling them consumers. Are they patients? Are they consumers? And then we've heard some kind of good stories around real consumer focus, like from Catherine, and really thinking about, well, people have to take a half day off work to get a test, and that's a problem, and let's solve that problem. Also the health system problem, but let's also think about it from the consumer angle. So there was a nice story there. I'm just wondering about, before I started working in healthcare, I was doing a lot of digital transformation in retailers and banks and media, and if you look at what's happened in the consumerization in those industries, and then in the health industry, it's like nothing in comparison in terms of an obsession with solving consumer needs. And so I guess when we think about what's happened in the first generation of virtual care and telehealth, there's a lot of thinking about the healthcare system's problems and solving those problems and the patient, and how can we help the touch points that we already have. But since the topic here is about more at home, many conditions are managed at home. 99% of diabetes care, for example, is done by an individual living their life away from the doctor, away from the healthcare system. And those problems feel like they just sort of get left out of the picture in this sort of current wave of virtual care. And so the question for the panel is, just what are you doing in your own organizations? What kind of radical rethinking happens when you look at the patient as a consumer and really think about the problems that they're dealing with and solving? Or is there even headspace to do that because it's such a complex industry? Like, is there room to even really think about, no, let's just completely forget the way we have it now and just dig into this person's life and how we can make them more well or make them better?
So a user, yeah, you're almost at usability, aren't you? The user.
Yeah, I'm just thinking about the framing of the problem as
a consumer-centric.
consumer
Paul,
problem.
how far are you doing that, Paul? I mean, it's a very good question, isn't it? I mean, there is a danger that we overlay. You've said this to me before, Cindy. The danger is that you overlay a digital solution on an analog problem, and effectively you only create a new digital layer. So you add costs rather than take them away as well. That's also part of this, isn't it? Paul, what about you? Are you looking at the consumer-centric? I mean, how far do you look at the patient-centric approach like that?
Yeah, absolutely. I think it's a great question. And the industries that you gave as an example, Cindy, as well with banking and retail, I think it's instructive that it was new players into those markets that actually led that disruption rather than the existing players. And I think the challenge for us in healthcare is that our user and our buyer, in many cases, are different. Right? Both, in fact, our clinical user and buyer are different, and then the patient or consumer at the end of the line, thinking in traditional terms, is a consumer, but in most cases not a payer. But I think our heart is actually consumer medical devices. So our whole kind of reason for being is in supporting people to manage their condition at home. But we had to do that through a combination of showing the benefits to clinicians so that they would even accept measurements done at home on a blood pressure monitor. And then, of course, focusing on how do you take what was seen as a very clinical tool into a home environment and to encourage people and give people confidence that they can do it. And that's very much the same with remote patient monitoring as well. Overcoming that kind of emotional barrier for people of the need to see a clinician face to face or to have that interaction and to demonstrate to them that they can achieve in their own kind of home environment and that they can be responsible for managing their own health. That's the really critical step to take. And for some users, that's natural. They're used to taking control in other areas of their life as well. But for a large proportion of people, they have been more passive consumers of healthcare in the past. And so absolutely understanding how you can empower those people to become active in managing their own condition and making it easy for them to do so. So some of the tools that are being used in finance, in retail, absolutely need to make their way into healthcare as well, in giving those micro rewards or those nudges to encourage people to healthy behavior. And it is the number one kind of objective of OMRAM with our remote patient monitoring, because if we don't satisfy the patients, then they will stop using the service, and then the value proposition doesn't work.
It falls to pieces. What about you, Carlos? I mean, very briefly, I'm nearly out of time, but I mean, obviously, Teledoc's been created by mergers and acquisitions and bringing together platforms. So I guess there is a danger, isn't there? That you then where's the patient centricity in this?
Yeah. On the other hand, the company has been always, as I said at the beginning, it's a patient. So it was born as a patient-centric company. It's not a hospital. We don't have brick and mortar.
Yes.
We really created the company as a company that is focused on to the consumer, and it's providing the right capabilities to the consumer. And when you think about these partnerships, of course, at the end of the day, going back to the concept of, well, how to become a global player, which is so complicated, but it's about having the right technology, the right capabilities, the right scalable technology, so that
Yes.
you can. And maybe the beauty or the advantage of having been born as a company in the US, which one of the first countries to really embrace virtual care and to make it available through different states with also different
Yes.
regulations, is that we gain a lot of volume size that allowed us to somehow provide and improve our technology. So then we can provide this to other communities around the world. And we have several examples that allows us to do this.
To do that. We're going to have to stop there, but I feel really that, you know, maybe you two would like to. There's a room just over there. I don't know, you probably go in there and find nobody follows you. But you could go in there and sit at a table, and other people in this break could go and talk to you both together like that if you wanted to. And that might be a good way of proceeding, yeah? So thank you very much indeed, panel, for a great session. I really appreciate it. Thank you.